Hi everyone, I'm Dr. Lakin Vira. I'm a general laparoscopic and laser surgeon associated with Apollo Group of Hospitals. Today we're going to talk about surgical complications and emergencies. So, what exactly are the two emergencies I'm going to be discussing today? Something which is very common, we see in our outpatient basis nearly every day. Topic number one is appendix, and topic number two is hernia. So, appendix. Well, appendix, to be actually speaking, it's a very easy topic because it's very common. I guess each and every one in your family, in your relatives, or in your nearby surroundings must have someone who has got an appendix problem, appendix surgery, or something related to it. What I would like to today emphasize with this short video is regarding the emergency associated with it and few complications that usually happen with it so that you get a better idea. What basically is appendix? Inflammation of the appendix region which is just next to the cecum. When it's inflamed, it's called acute appendicitis. Over the last many years, the cases of acute appendicitis has slightly increased. Most of my patients' first question is always, Sir, क्यों हुआ है? Why have I got this appendix? To be very honest, even now, there is no straightforward, clear idea of why appendix happens. What is the nomenclature which usually is given is small feculates, small areas of feces which get stuck at the base of the appendix, causing it for reduced blood supply and inflammation. What are the symptoms usually patient comes with? We have something called as a modified Alvarado score for it. The common things that we see is pain, fever, nausea associated and vomiting. Where exactly is the pain? It usually classically starts in the umbilical region, then it radiates and migrates towards the right iliac fossa region. Do you really need any investigations? Because many of the patients keep coming and say कि नहीं सर आप बोल रहे हैं अपेंडिक्स है बट हमको सोनोग्राफी कराना है सीटी स्कैन कराना है. To be very honest, we were always taught and were told to follow the modified Alvarado score, where if it crosses 9, where you have all the classical signs and symptoms, that is pain, fever, nausea, vomiting, raised WBC, migrating RIF pain, to be honest, you don't require much investigations. But in today's day and age, it is always better for the patient where even their relatives are satisfied. We usually go for a sonography or in some cases the CT scan. Usually it's very easily diagnosed as acute appendicitis. Treatment is straightforward. Laparoscopic appendicectomy. Now, there is always a controversy which has happened over the last many years. Laparoscopy or open, laparoscopy or open. To be honest, to all my patients who I see in OPD, I always give a laparoscopic option first. There are one, two advantages that we really are going for. That's why we think about laparoscopy. In laparoscopy, what we basically do is the first step is we take a small incision here and we put a camera inside. With that, what happens? I get a very good visualization and idea about the complete bowel. I can check the bowel right from ileocecal junction to DJ. I can check for any small Meckels. I can check for any other problems which are associated around, any inflammation, and if anything is there, I can pick that up, take photographs, and guide the patient regarding in post-op also. What the surgery done is laparoscopic appendicectomy. It's a very straightforward 1.5 hour surgery. Post-operative stay is usually only 1 day. Next day patient is home. We usually start liquids little slowly in case of appendix because inflamed. We have chances of nausea, vomiting post-op, and patient goes home after 1 to 2 days. Now, what I would like to discuss is some problem that I've many times faced. Sir, pain तो बहुत थोड़ा है. Appendix में ज़्यादा ऐसा issue नहीं लग रहा है. मेरे घर में आजू बाजू में भी 1-2 लोग थे. They had appendix, sir. उन्होंने गोली से ठीक हो गए. To be honest, I'll give a very clear answer for that. What they were undergoing that time was absolutely correct. Because in case of mild cases, I completely agree. Just simple painkillers, good antibiotic for 3 to 5 days, the inflammation will subside. But that is short term. Your appendix problem is going to come back. What I tell my patients is, आप appendix को भूल जाएंगे, वो आपको नहीं भूलेगा. It is going to come back. It usually comes back after around 4 weeks to 6 weeks. The problem here is, it comes back in a more scarier way. The pain is more. There is more high-grade fever, vomiting, and chances of complications also, which I'm going to talk in the end. So I would suggest to everyone, If you are getting an inflamed appendix, infection in the appendix region, please don't delay it, because there is no way you're going to get out of it with only tablets. Even if you do, it is temporary. So it is always better to just get your checkup done and discuss with your doctor regarding the surgery for it. Because to be honest, there is no medical treatment for appendix ever. It is always surgical. Now, what complications I was trying to imply? See, two common complications that we have seen in majority of patients who delay discussing about it, delay surgery or some other reasons. One is appendicular abscess. Second is perforation of the appendix. Now, what exactly happens? We all have a slight idea appendix is a long tubular slender structure, usually around 3 to 4 centimeters. When inflamed, it may go up to 8 centimeters also. What happens? The tip perforates. Now, when this tip perforates, what exactly is the problem that happens? See, it is all intra-abdominal. So, there is bowel around it. There is omentum around it. If it gets stuck out there, then the surgery itself becomes complicated. Many times it is stuck to the cecum. Complete excision and removal of the appendix becomes a problem because it is stuck to the surrounding bowel. We can't make a hole in the bowel. So what happens is, that is one reason why we ask for earlier admission, earlier surgery to avoid these kind of problems of appendicular perforation. Lastly, coming to abscess. Now what happens? Suppose it is a month of January, you've come with appendix issue and you don't want to get it treated. You wait till February, you wait till March. Intra-abdominal, there is microorganisms which are there. There is an inflamed appendix that stays out there, and especially if in diabetic patients, little old age patients where the immunity is little lower, infection starts. That infection surrounds that area and there's a good amount of abscess which happens, which not only makes your surgery difficult, also it causes high grade fever, severe pain, and a simple straightforward surgery becomes a complicated one and your recovery becomes delayed. For a laparoscopic appendicectomy, usually we have surgery and patient post-op day 1 discharge. 3 to 4 days he is back to working in office. In case of appendicular abscess, appendicular perforation and such, we have 7 days to 14 days where patient needs to take rest at home. So my whole idea today with all of you friends is to discuss, don't take appendix lightly. One other example that I always give my patients, once appendix is diagnosed in your family, in your friend circle, please take it as a priority. Because if taken on a priority basis, treatment is fast, smooth and recovery is very nice with absolutely no long-term problems. 1-2 other problems that some of my patients have asked is, sir appendix तो अतड़ी है, अतड़ी का भाग है, आप उसको निकाल देंगे, कोई problem नहीं, कुछ उसमें कुछ होगा नहीं. So that is what I wanted to address also is, see, appendix is something called as a vestigial organ. It is a waste organ. I have an appendix, you have an appendix, we all have it. But does it do any function? No. So is it safe to remove? Definitely, it's absolutely safe to remove and there's no issue. The other thing what I see very commonly in my OPD is hernias. Now again hernias, I mean, you all are not doctors but we all know what is a hernia. Basically it's an outpouching of the bowel which is seen. Again, just like appendix, in your family, surroundings, neighbors or in your office, someone must have had a hernia, must be having a hernia, must be delaying it, or just got operated and discussing with you about how his procedure was. Now in a hernia there is 2 parts to it. One is the emergency associated with it and other is the elective. I have to be honest, hernia is not always an emergency. If I see 10 hernias overall in a 15-day span, only one is usually coming with an emergency with complications. Since today's topic is about emergencies, we will first discuss that few types of hernias where there is an emergency, where there is some pro-action and quick action needs to be taken. Now, hernias kind of forms complications. This is because, as usual, most of the patients with hernia wait for 2 weeks, 4 weeks, can even be up to 2 to 5 years. Just 3 days back, I had a patient who had 8 years waiting for a hernia. He still did not have a complication. So I would like to say that I am not trying to say any wrong figures. All I am trying to say is hernia can also form an emergency. What is the emergency that we see in case of hernias? One is obstruction, second is strangulation. Now, what is obstructed and what is strangulated hernia? Obstructed hernia where the contents of the hernia at the level of the sac are obstructed. How is it different from strangulation? In strangulation, the blood supply starts getting affected. The blood supply of the bowel is reduced significantly. That is an absolutely grave emergency. No discussion, admit, get the investigation done and do the surgery. Now, what do we exactly do if we land up with a hernia which is obstructed or strangulated? And friends, at your level, how would you know if your hernia is obstructed or strangulated? See, one very important symptom that is associated with appendix, with obstructive strangulated hernia is pain. That area which is affected has a lot of pain. In obstructed and strangulated hernia, you see discoloration, you see reddish color out there. That is basically because the blood supply is reducing and lot of fever, lot of vomiting. In such cases, please avoid over-the-counter medications. Please avoid self-medications or any kind of treatment from just your friends or some past experiences. Please, it's always better, show a doctor. Now, what is our approach when you have an obstructed hernia or a strangulated hernia? It's usually very clear, self-diagnostic. We do sometimes do some kind of investigations like sonography, if required, just to see what the sac is, how big is it, and what are the contents associated. And most important, how is the blood supply? Is it really affected? Treatment in these cases again is admission, start good amount of IV fluids, IV antibiotics, and post the patient for exploration. What we basically do is we explore, get to the sac, and first of all understand the contents. And as I said, strangulated, where is the blood supply reduced or the blood supply is normal. What we usually do is we check the color. Color is a very simple diagnostic method of the bowel or whatever the hernial contents are to see whether the blood supply is normal or not. Suppose if the blood supply is good, all we have to do is wait for 2 minutes, see the blood supply is good, deposit all the bowel back to the abdomen and do the rest of the closure, that is hernioplasty. Now, what exactly we do later on, as I discussed, is hernioplasty. We all know in hernias there's a defect, there's a gap through which bowel or omentum is coming. If it's obstructed or strangulated, as I said, we deposit it back after checking the contents. Later on, the steps are simple. Whatever the gap is there, a 2-layer closure is done, which is called as herniography. After that, we put a mesh. The most common and the best meshes available, the Prolene meshes. Different sizes and shapes are available as and how we require. Usually, the most common are 3x6 meshes used for open surgery, and patch meshes or the Ventralex EPOM meshes are available when you go for laparoscopic surgery. Please remember, 20 years back, we did not have much of the scope of mesh. Now, I guess I don't need to teach you all or discuss. You all also know, yes, mesh is important. Yes, mesh is compulsory. A very few cases where we avoid meshes are what I was discussing earlier. Obstructed cases, strangulated cases. What happens if the strangulation is severe? Some amount of bowel, severe restriction, some perforation associated. If perforation is there may be feces along with it. So when such kind of infective situation is there, putting an implant, putting a mesh can cause severe complications. So those are the 1% of cases where we kind of avoid the mesh. Again, like appendix, recovery in hernia surgery is not very long, takes around 1 or 2 days. Only for obstructed or strangulated cases, we may be admitting for 2 or 3 days extra and giving some IV antibiotics and IV fluid to supplement. Recovery is quick and everything goes smooth. In terms of hernia, there are just few doubts that I sometimes get in my OPD which I would like to share with you all. One debate which I guess not for 10 minutes, I can go for hours, and I guess many of my surgical colleagues and all, what you must have also undergone when you talk to a doctor is open surgery or laparoscopic surgery. I try to smoothen that discussion in a very simple way. I always go for laparoscopic surgery. When do I not go for it? When do I not go for it is, if you understand, laparoscopic surgery needs full anesthesia. So who should you not do laparoscopy? Who are unfit for full anesthesia. Who is usually that? Patients may be around 70, 75 years and above. Any major cardiac events like heart attacks, which has eventually led to angioplasties, bypass surgeries, or any other major surgery is there where the patient becomes a high risk for general anesthesia. Now, if the patient is anyways high risk for general anesthesia, why do you want to take a risk for such a simple, uncomplicated surgery like hernia? Go for the local anesthesia, that is what we call as spinal, do the open surgery. In both cases, trust me, recovery is one day, you will be absolutely okay. Your doctor may have suggested you open surgery. Trust me, he must have thought about it, thought about the complications and the long-term recovery, and then only must have suggested you. It is absolutely safe, just like laparoscopic surgery. In laparoscopic surgery, we have two common types that we deal with. One is TEP, one is TAPP. Not trying to get it complicated, I would just like to give you simple TEP. E is extraperitoneal and A is abdominal. So what we do in TEP, we do not enter the abdomen. It is in the extraperitoneal plane that we go. We completely dissect all around and we put a large mesh. Most commonly and safer is TEP. Your doctor must have to usually suggest you for TEP, something that I do regularly in my surgical OPD, because TAP is a little bit of a easier procedure but definitely has some kind of major complications associated. So only done reserved for cases where there are very large intra-abdominal or inguinal hernias where you may do TAPP. Again, a lot of questions asked, nahi sir, open surgery, recovery, what time ye wo lagega? Trust me, things are very different. The surgical instruments and the post-op management is such. Maybe 1 or 2 days, even in open surgery, you will be absolutely okay. Are we dealing with major complications post-op? Not really, because appendix surgery both open as well as laparoscopy. No real complications. It's usually smooth and there is just some kind of pain. What sometimes we see is scrotal edema. Now what happens is your hernial sac is associated with the cord structures. Whenever you go for surgery, for us, while we are operating, you need to move around the cord structures, be it open or be it laparoscopy, to ensure that all your hernia is completely cleared, all of the contents are clearly reduced, and the whole area is absolutely plain before we put the implant, that is the mesh. So in such cases, what we ensure is, as the area is completely clean, we put the mesh and smooth recovery is there. So friends, what I would like to suggest is, it was a very simple topic, I agree, but all I wanted to do today is stress out. Appendix, do not self-medicate, do not self-treat, and please show your doctor. Whereas case of hernias, if you have pain or any other symptoms, do not delay. Thank you so much.